Hi, my name is Professor Len Calabrese from the Cleveland Clinic, and I am delighted to present highlights of the ACR Convergence 2020 on behalf of the Cytokine Signaling Forum. ACR kicked off yesterday with the opening session, Rheumatology Strengths, Science, and Resilience. It was chaired by our president, Dr. Ellen Gravelisi. The session featured Editor-in-Chief of the New England Journal, Eric Rubin. If you haven't seen it already, we recommend watching his presentation, COVID-19, the Convergence of Infection and Inflammation. Thursday represented only the very tip of the iceberg, with a wealth of data being presented over the coming days. The CSF have chosen a selection of highlights with the aim of sharing the most notable abstracts in cytokine signaling science with you. I'll now review Friday's highlights. This is entitled RA Treatments and Their Safety. The RA Treatment Poster 1, RA Treatments and Their Safety session featured some of the most fantastic posters of the session, I believe, 4 of which I'd like to highlight now. These included the latest safety data from clinical trials programs from upadacitinib, baricitinib, and filgotinib. The first poster from Professor Kevin Winthrop and colleagues evaluates the safety data from the baricitinib clinical trial program, which now extends out to 8.4 years. So the background of this is to study bara over long-term treatment, which is now, as I said, extended over 8.4 years. To do this, they collated 9 completed clinical trials, which range from 1B to 3, with ongoing extension. I think it's important to note that there's now 3,770 patients, and this now covers over 13,000 patient years, and it had a median and maximum exposure of 4.2 and 8.4 years respectively. This is really important in the world of safety science to get over that 10,000 patient year mark, in my belief. Incident rates per 100 patient years for any treatment emergent or serious adverse event, including death, were 25.8 and 7.2 respectively, while rates for MACE, DVT, PE, and non-melanoma skin cancers remained very stable over time. There was no increase in death or non-melanoma skin cancers after adjusting for the aging of the cohort. So in summary, the incidence rates across safety topics for bara, now reaching 8.4 years, are consistent with all previous analysis. The next poster is an update on the safety profile of upadacitinib. Now this only has 3-year data because it's the newest, at least in the United States, JAK inhibitor. This was presented by Professor Stanley Cohen and his colleagues. The background is that UPA has been evaluated across the spectrum of RA patients in all the phase 3 select clinical trial program. And this study was designed to interrogate long-term integrated safety profile relative to active comparators. So when examining these, the exposure-adjusted event rates, adverse events leading to discontinuation, SIEs, and opportunistic infections were comparable between UPA-15, methotrexate, and adalimumab, but were higher in the 30 milligram dose. And as I'm sure you're aware, in the United States, this dose was not approved. Rates of non-melanoma skin cancers were similar between UPA-15 and adalimumab, but again, higher for the 30. Rates of zoster were higher in both UPA groups compared with methotrexate and adalimumab. It was palpably higher in the 30 milligram group. Number of deaths in patients exposed to UPA was not higher than would be expected in the general population, so we conclude that the long-term follow-up of RA treated with UPA demonstrates a consistent safety profile with no new safety aspects identified. Moving on now, let's talk a little bit about filgotinib. This study is from my fellow CSF steering committee member and good friend, Professor Kevin Winthrop, and his colleagues, who presented data on up to 5.5 years. The safety profile of Filgo has been shown to be comparative to adalimumab and methotrexate. And this study provides an integrated safety analysis of the phase 3, phase 2, and long-term extension studies, which now go out to about 5.5 years to get a more granular view of this. In the placebo set, rates were comparable between Filgo 200 and 100 and placebo. And both of those doses have been approved in Europe. And that's for treatment emergent and serious adverse events, and those leading to discontinuation or death. As in the as treated set, the exposure adjusted incidence rates were lower with Filgo 200 versus 100, which is interesting, but comparable between doses for SAEs, treatment emergent events leading to discontinuation, death, and MACE. All and serious infection rates were higher for filgotinib versus placebo in the placebo set, and for Filgo 100 versus 200 is in the as treated set. So this is the first time we've seen anything like this in terms of this dose, which is curious and interesting. So in summary, Filgo was well tolerated over 5.5 years of follow-up with infrequent VTE and other adverse events of special interest and no new safety signals. The next study is from Professor Eduardo Meisler and colleagues and analyzes the impact of UPA or adalimumab as initial therapy on the achievement of 48-week treatment goals. The background of this is the Select Compare program we've already discussed a bit. Insufficient responders to initial therapy were at week 26 switched from UPA to adalimumab or vice versa if they weren't at target. The study assessed the one-year treatment outcomes according to the initial randomization, regardless of how they were switched. So there were 651 patients randomized to UPA and 245 switched to ADA. There were 327 initially randomized to ADA and 157 switched to UPA. At week 48, similar proportions of patients initially randomized to UPA or ADA achieved low disease activity. And the numbers are shown in parentheses, as well as DAS-CRP. And again, the numbers are shown on the slide. So regardless, the proportion of patients achieving low disease activity or remission at 1 year were similar, regardless of how patients were initially randomized to either upadacitinib or adalimumab. The next poster I would like to highlight in the RA treatments and their safety session is the incidence and risk of venous thromboembolism in upadacitinib clinical trials program. VTE is probably the most concerning class associated toxicity, which has generated black box warnings by the FDA. So any data that we glean over long-term analysis is important. So we know that patients are at increased risk for development of VTE, PE, and DVT just on the basis of having rheumatoid arthritis and having an inflammatory state. So this study describes the incidence in patients receiving UPA relative to active comparators in the SELECT program, and it looked at potential risk factors. So the exposure-adjusted treatment emergent adverse event rates and per events per 100 patient years of VTE were 0.5 for UPA 15, 0.3 for UPA 30, 0.5 for ADA plus methotrexate, and plus 4 for methotrexate. So no palpable differences here. Univariate analysis identified prior history of VTE and body mass index, both risk factors for cardiovascular disease, as factors associated with VTE at UPA 15 and 30. Age and NSAIDs were factors for UPA 15 dose only. So again, despite the fact that there is a background signal within this class, more carefully analyzed studies show that VTE rates were balanced across UPA doses and active comparators. Risk factors associated with VTE included prior history of VTE and BMI. So we are left with the recommendation that we need to risk stratify patients before we consider this class of drugs. And if we do, I think that careful monitoring is not only appropriate, but an adequate safety measure when we deem that the benefits outweigh the risks. The posters in this section focused on efficacy in addition to safety. And Professor Bernard Combe and his colleagues presented 52-week Filgo data from the Finch 1 study. And remember that this study assessed efficacy and safety of Filgo in methotrexate IR RA patients. The analysis presents results from Finch 1 up to 52 weeks. 81% plus of the 1,417 patients received study drug through week 52 were female, with a mean RA duration of 7.8 years, so it's a long-standing cohort, with DAS-CRP at baseline of about 5.7. At week 52, DAS-CRP less than 2.6 was achieved by 54, 43, and 46% of patients taking Filgo 200, 100, or adalimumab. So you can see the dosing ranges respectively. And the adverse events of interest were infrequent and balanced across the treatment limbs. So this is another study of filgotinib showing that efficacy sustained at 52 weeks at both doses and was well tolerated in the methotrexate IR patients with RA. The next professor was presented by another fellow CSF steering committee member, Professor Peter Nash. This study analyzed the sustainability of response between UPA and ADA in patients with an inadequate response to methotrexate. So we know that the goal of RA treatment is a state of sustained remission or low disease activity. And this study assessed the long-term sustainability of response to these two drugs, UPA and ADA, both with background methotrexate in patients with prior inadequate response to methotrexate. This is the Select Compare program. So the key results show that a significantly higher proportion of patients receiving UPA and methotrexate achieved CDI remission at week 72 compared with adalimumab and methotrexate. The p-values and percentages are shown, as well as CDI low disease activity. At 6 months, the first occurrence, 26% of UPA methotrexate and 16% of ADA methotrexate patients achieved sustained CDI remission, and 49% of the UPA methotrexate and 36% of the ADA methotrexate patients achieved sustained CDI low disease activity. And at 12 months after the first occurrence, 22% of UPA methotrexate and 14% of ADA metho patients achieved sustained remission, and 46% versus 34% in the UPA ADA achieved sustained low disease activity. So this is an important study. Every JAK inhibitor has taken on a TNF inhibitor, by and large adalimumab, in every way, shape, and form. And in this study, there was consistent superiority of UPA methotrexate versus adalimumab methotrexate for both low disease activity and remission. So another important piece of data in this study. So there's a running theme at this year's ACR convergence with a number of posters focusing on the effects of JAK inhibitors on bone health. To find out more, make sure to watch out for the highlights over the next few days, but I will point out our next poster by Dr. Attila Hamar and colleagues looking at the bone effects of 1 year of tofacitinib treatment. So in this space, we don't have a whole lot of granular data about how JAK inhibitors in general or tofacitinib affects bone structures and turnover markers. So this study attempted to do this over a 1 year time frame. We know that tofa significantly reduces disease activity, and it was shown to reduce DAS28 and HAC, as well as lower the level of CRP. And in this study, significant increases in the levels of osteocalcin, osteoprotegrin, sclerostin, and vitamin D were seen at 6 months, and in levels of osteoprotegrin and vitamin D at 12 months, and a decrease in C-terminal telopeptide observed at 6 and 12 months. Patients receiving TOFA 5 milligrams BID saw an increase in the levels of procollagen, N-terminal propeptide, osteoprotegrin, and vitamin D at 6 and 12 months, and osteocalcin at 6 months only. Patients receiving TOFA 5 BID saw a decrease in phosphate and C-terminal telopeptide at 6 and 12 months. So these are a lot of bone markers, but at 1 year, TOFA appeared to stabilize bone density in patients with RA and led to increase in bone turnover markers. Thank you for tuning in to the CSF Daily Highlights. We hope it's been informative. Look out for tomorrow's edition, available on our website, cytokinesignaling.com, and on YouTube, Cytokine Signaling Forum. The CSF is providing extensive coverage of 2020 ACR convergence on the CSF website. You can find our full abstract search and recommendations in our highlights brochure, which is available now. Look out for presentations from authors of notable papers, as well as our highlights from ACR course, where we'll go into more detail on some of the most notable abstracts presented. Thank you.